In this video, we will cover seizure disorder. Seizures are episodes of abnormal motor, sensory, autonomic, or psychic activity, or a combination of these, that results from sudden excessive discharge from cerebral neurons. Seizures occur when abnormal electrical signals are being rapidly fired for neurons in the brain. During a seizure, multiple neurons fire at a rate much faster than normal, causing involuntary movements, sensory phenomena, emotional expression, and unusual behaviors. This can happen throughout the brain, affecting both sides, that is generalized seizure, or being located in a specific area of the brain, that is partial or focal seizure. Seizures may accompany a variety of disorders or occur without any apparent cause. Seizure disorder or epilepsy is a group of neurologic diseases marked by recurring seizures. If a person has 2 or more seizures more than 24 hours apart without an underlying problem that caused the seizure, they may have seizure disorder. Seizures from systemic and metabolic problems are not seizure disorder if they stop when the underlying problem is corrected. Now let us see the pathophysiology of seizure. The cause is an electrical disturbances in the nerve cells in one section of the brain. These cells emit abnormal, recurring, uncontrolled electrical discharges. The characteristic seizure is a manifestation of this excessive neuronal discharge. Associated loss of consciousness, excess movement, or loss of muscle tone or movement, and disturbances of behavior, mood, sensation, and perception may also occur. The specific causes of seizures are varied and can be categorized as genetic due to a structure or metabolic condition, or the cause may be yet unknown etiologies. In the brain, our neurons are tasked with handling and transmitting information. There are 2 types of neurons. These are excitatory and inhibitory neurons. Just like their name says, excitatory neurons produce an action or cause excitement by releasing a neurotransmitter called glutamate. This is an excitatory neurotransmitter. Inhibitory neurons stop an action or cause inhibition by releasing an inhibitory neurotransmitter called GABA, gamma aminobutyric acid. There needs to be a proper balance between these 2 types of neurons for seizure activity not to occur in a healthy brain. If there is an imbalance of excitatory neurons versus inhibitory neurons, seizure will occur. For example, if there is not enough GABA, that is inhibitory neurotransmitter, being released, too much excitation will occur leading to a seizure activity. For instance, barbiturates stimulate GABA receptors which help control excitation and decreases seizure activity. Now we will see causes of seizures. It can be because of cerebrovascular disease, hypoxia of any cause including vascular insufficiency, can be because of a fever, especially in children, head injury, hypertension, CNS infections, metabolic and toxic conditions, for example, kidney injury, hyponatremia, hypocalcemia, hypoglycemia, pesticide exposure. It can be because of a brain tumor, can be because of drug and alcohol withdrawal allergies. Now let us see the stages of experiencing a seizure. We can divide how a person experiences a seizure into stages. It varies depending on the seizure type. First stage is prodromal stage, when symptoms start to appear prior to the big event, hence seizure. It can start days before a seizure happens. Patient may have mood changes such as depression, anger, issues sleeping, anxiety, GI and urinary issues, etc. Next stage is aura. Doesn't happen with all types. It happens at the very beginning of the seizure, mainly in focal seizures or in a tonic-clonic seizure. Happens within seconds to minutes before a seizure. Many times it gives the patient time to prepare self for seizure. If we are present as a nurse, help the patient lay down onto their side with a pillow under the head. Symptoms vary among patients but can include sudden weird smell or taste, deja vu feeling anxious like something bad is going to happen, altered visions, lights or spots in vision, or hearing hallucination type sounds or increased ability to hear sounds. Patient may feel dizzy, different for every person. Patient may have inability to speak. Next stage is ictus. The ictus meaning is seizure. This is the actual seizure. Usually lasts anywhere from 1 to 3 minutes. We have to time the seizure. Seizure is greater than 5 minutes, or if the patient starts having seizure back to back, the patient may be experiencing status epilepticus. Patient may need medical care and medication to stop seizure. It will unlikely stop on its own. Post-ictus, that means after the seizure. Brain is going to rest and recover from seizure. Usually lasts hours to days, especially in tonic-clonic seizure. For some patients, it is immediate, that is in absence seizure. Patient may feel extremely tired, sleepy, confused. Patient may have headache, etc. Next, we will see the types of seizures. Seizures are classified as generalized, partial, and unclassified or unknown. It is classified as depending on the area of the brain involved. Generalized onset seizure divides into two types, motor and non-motor or absent seizure. Motor seizure subdivides into atonic, clonic, epileptic spasms, myoclonic, atonic, myoclonic, tonic-clonic, tonic-clonic. Non-motor seizure divides into typical, atypical, myoclonic, eyelid myoclonia. Focal onset seizure divides into simple partial and complex partial. This depends on the awareness or consciousness of patients. Focal onset seizure divided into motor onset seizure and non-motor onset seizure. Motor onset seizure is divided into automatism, atonic, clonic, epileptic spasm, hyperkinetic, myoclonic, tonic. Non-motor onset divides into autonomic, behavior arrest, cognitive, emotional, and sensory. Generalized seizure is affecting both parts of the brain. Generalized seizure are characterized by global synchronized activation of neurons, resulting in impaired consciousness, bilateral motor changes, and EEG abnormalities. Now, let us see the seizure types and meaning. Generalized motor seizure, in that myoclonic. In this, quick duration of jerking of the muscles occur. Patient usually aware and conscious. This is what makes it different from a clonic seizure. It is very short, lasts only for a few seconds. Atonic. Without muscle tone, the patient goes limp and falls if standing or slumps over if sitting, at risk for head injury. Patient may need helmet to use, usually not aware during event. Post-ictus, that is, the patient regains consciousness immediately. Myoclonic, tonic-clonic seizure. This seizure is usually observed in individuals with juvenile myoclonic epilepsy. It is characterized by arms jerking, then tonic stiffening, and lastly, clonic rhythmical jerking. Myoclonic atonic seizure. This seizure is commonly seen in patients with Deuce syndrome and was previously referred to a myoclonic astatic seizure. It is characterized by brief jerking of limbs or trunk followed by a limb drop. Tonic-clonic seizure. This is most common type of generalized seizure, formerly called grand mal seizure. Patient may experience aura, warning a seizure is about to happen, loses consciousness at risk for injury, will experience a tonic phase first, body stiffens, may bite inside of the cheek or tongue, may see blood leaving mouth with forming of saliva. Patient may stop breathing followed by cyanosis. Then the patient will have clonic phase. Recurrent jerking of extremities will take place. Spasm and relaxation back to back. Patient may have incontinence of stool or urine. Usually lasts no more than 3 minutes. Patient is at risk for status epilepticus with this type of seizure. If greater than 5 minutes or having multiple seizures in a row, active emergency response team to be arrived. Will need immediate treatment to stop seizure. Post-ictus period is hours to days. This is the recovery period. Patient will feel very tired, extremely sore from muscle stiffening and jerking. Can't remember what happened. In tonic seizure, patient will have stiffening of the body. Patient is at risk for falling. In clonic seizure, jerking of extremities will take place. It can be symmetrical or asymmetrical. Next is generalized non-motor seizures. In that, absent seizure, formerly called petit mal seizure. Most common in pediatric patients, and hallmark is a stirring-like state. It will be like the child is just daydreaming, but it can't be snapped out of it. Can go unnoticed by others for a while because it's short and the child won't remember it. The person will look confused and won't be able to talk during the event. It is very short and lasts only for few seconds. In post-ictus, patient doesn't remember staring off. Typical absent seizure. These seizures are characterized by interruption of activities that occur suddenly with a blank stare and occasionally associated with the deviation of the eyes that lasts for a few seconds to half a minute with subsequent rapid recovery. May be associated with flicking of eyelids. Atypical absent seizures. It has a slow onset with significant changes in muscle tone that is more pronounced than a typical absence. It has a slow spike waves at EEG, usually less than 3 per second. A myoclonic absent seizure. This seizure starts with few rhythmical jerks, which is then followed by a stirring spell. Next is eyelid myoclonia. In this seizure, there is a sudden forceful upward jerking of eyelids, which may be associated with the stirring spell. It usually stimulated by the closure of the eyes. Next is focal. It affects a specific part of the brain. It has two types. Now the main difference is which is that with the focal onset aware, this patient is aware of their surroundings, but with focal impaired awareness, that is complex partial, the patient is not aware of their surroundings and will have motor symptoms called automatism. Focal onset aware, that is simple partial. Symptoms vary depending on where the seizure is located. It tends to be a small area of a lobe, but patient is aware. Example, occipital region. The person may have vision changes. Also sometimes called an aura too, because it can happen right before focal impaired awareness, that is complex partial. Focal impaired awareness, that is complex partial. Patient may have alteration in awareness and has motor symptoms. Temporal lobe most commonly involved in focal impaired awareness. Focal onset aware, that is aura, can happen before impaired awareness. In this automatism present, this is where they are performing an action without knowing they are doing it, like lip smacking, rubbing hands together, or grasping for something that isn't there. Next is focal motor. In that, focal automatism seizure. It is commonly misdiagnosed and disregarded as a seizure. It is repeated motor activity that usually occurs under impaired awareness and sometimes followed by amnesia and characterized by repeated action such as saying something repeatedly, lip smacking, rubbing, or wandering. It is a common feature of focal impaired awareness seizure. Next is focal atonic seizures. Seizures with loss of muscle tone that occurs suddenly and lasts for a few seconds. It can occur on one side of the body or in one limb. Awareness is usually retained after the seizure. Focal tonic seizure. Seizures with a sustained increase in muscle contraction that lasts for a few seconds or minutes and present clinically as stiffening of a limb or the neck. Next is focal clonic seizures. Sustained rhythmical jerking of a group of muscles that occur either symmetrically or asymmetrically. Next is focal epileptic spasm. The patient may have sudden, uncontrolled, and sometimes painful muscle contractions that commonly occur in children. Clinically present as sudden flexion of the waist and flexion or extension of the arms and legs, which may occur in clusters and can be focal, generalized, or unknown onset. It is usually diagnosed by video EEG. When it occurs in infants, it is called infantile spasm. Awareness is usually retained after the seizure. Focal hyperkinetic seizure. Seizures associated with an exaggerated and often uncontrolled muscles activities such as agitated kicking, thrashing, and pedaling during the seizure. Next is focal myoclonic seizures. It may be similar to clonic seizures but are usually brief and sustained muscle contractions that occur suddenly and last for few seconds or even less than a second, or just an irregular jerking in one part of the face or body. Awareness is usually retained after the seizure. Next is focal non-motor. Focal non-motor autonomic seizures. These are seizures affecting autonomic nervous system presenting with symptoms like rising sensation in the stomach, hot and cold feelings, a strange taste or smell, etc. Next is focal non-motor behavior arrest seizures. These are seizures presenting with the cessation of all activities and unresponsiveness for the entire duration of the seizure event. Next is focal non-motor cognitive seizures, when there are hallucinations, illusions, deja vu, or impaired speech. During the seizure event, the patient is said to have had cognitive seizures. Next is focal non-motor emotional seizures. These seizures refer to a non-motor seizures that begin with panic, anxiety, fear, joy, crying, depression, or any other emotions. Next is focal non-motor sensory seizures. These seizures present with abnormal sensations such as visual, olfactory, auditory, gustatory, somatic hallucination, or vertigo. The unknown type includes epileptic spasm. Unclassified seizures are so termed because of incomplete data but are not considered a classification. Seizures may also be characterized as provoked or related to acute, reversible conditions such as structural, metabolic, immune, infectious, or unknown etiologies. Now let us see the assessment and diagnostic methods. Developmental history and physical and neurologic examinations are done to determine the type, frequency, and severity of seizures. Biochemical, hematologic, and serologic studies are included. Magnetic resonance imaging is performed to detect structural lesions such as focal abnormalities, cerebrovascular abnormalities, and cerebral degenerative changes. EEG is done to aid in classifying the type of seizures. Single photon emission CT may be used to identify the epileptogenic zone. Now let us see the medications. Medications treat based on type of seizure. Carbamazepine is used to treat focal seizures. Example, carbatrol, tegretol, epitol, equitrol, including ones that occur in the temporal lobe. This medication may also help treat generalized tonic-clonic seizures, refractory epilepsy, which is resistant to treatment, mixed seizure types, which are a combination of focal and generalized seizures. Next medicine is levetiracetam. Example is Epilepsy XR, Keppra XR, Spritam. It may treat a range of epileptic seizures, including focal seizures, generalized tonic-clonic seizures, myoclonic seizures, juvenile myoclonic seizures. Next is barbiturate. Phenobarbital used for tonic-clonic or focal seizures and status epilepticus. It stimulates GABA, that is gamma aminobutyric acid receptors, and this helps inhibitory neurotransmission. The side effect is drowsiness, uncoordinated movements, that is ataxia. We have to watch for respiratory depression and hypotension. The therapeutic reference range of phenobarbital is 15 to 40 mcg per ml. Next medication is hydantoins. Phenytoin is a drug of choice used in tonic-clonic or focal seizures. The therapeutic level is 10 to 20 microgram per ml. We have to watch the gums for gingival hyperplasia. The gum will enlarge and easily bleed. Teach the patient about good mouth care. Phenytoin may cause bone marrow suppression, so we have to watch platelets and WBC counts. Tell the patient to watch for rash or Stevens-Johnson syndrome and to report it to their doctor immediately. Don't give milk or antacids. It can interfere with the absorption of phenytoin medications. Stevens-Johnson syndrome is a rare and extremely serious condition that causes your skin to come loose and detach because of the reactions of some medications. Next medication is benzodiazepines. The drug clonazepam or clonopin is a long-acting benzodiazepine. It is used to treat many types of seizures, including myoclonic seizures, absence seizures, atonic seizure. Atonic seizure causes a loss of muscle tone and may begin in one or both areas of the brain. Next is lorazepam, is a benzodiazepine that's used to treat all types of seizures. It is also used to treat status epilepticus. Status epilepticus is a prolonged critical seizure that's regarded as a medical emergency. Next is diazepam or Valium, Valtoco, Diastat. Is used to treat clusters of seizures as well as prolonged seizures. This medication is also a benzodiazepine. Diazepam is a rescue medication that's often used to relieve symptoms in an emergency. It's rarely taken as a daily medication. After taking this medicine, the patient may feel very drowsy. Patient may develop tolerance where it isn't as effective. Patient may have impaired liver function, so we have to monitor liver function studies. Next drug of choice is valproate, valproic acid. It is given to all types of seizures. We have to monitor liver function, WBC, platelets, and GI issues. Other treatments include surgery to remove an area of the brain that is causing the seizure. For example, focal seizures that arise from temporal lobectomy to be done to the patient. If the medicine is not working, placement of a vagus nerve stimulator is to be applied. It is an electrical device that sends electrical signals to the vagus nerve. Patients should be given ketogenic diet used in pediatric patients who have epilepsy. That is high-fat, low-carb diet used when seizures not controlled by medication. Now let us see the nursing interventions for seizures. Assess risk factors for seizure. Any patient can experience this if any of the causes mentioned above are present. So we have to be prepared. If risk factors present, initiate seizure precautions. Seizure precautions may include: at bedside, we have to keep suction and oxygen ready. IV assessed to keep ready to give anti-seizure medications if needed. Padded side rails. Pillow under head to protect head. We have to keep bed in the lowest position. Remove objects that can cause injury. Remove any restrictive clothings or items the patient may be wearing or eyeglasses, etc. Assess the patient if the patient is having any history of seizures in the past, and if so, what type of seizure. Ask if the patient experiences prodromal signs and symptoms or an aura before the seizure. How long does the seizure last? If the patient is able to report prodromal or aura, help a patient prepare by getting the patient in a safe position by lying down on their side. What to do when the patient has a seizure? Protect patient if they are standing up or sitting down by gently lying the patient down and turning them onto their side. This helps prevent the tongue from covering the airway and helps saliva and blood drain from the mouth. Do not restrain patient or try to hold the patient down. Protect their head and extremities. Pillow and bed parts will help with this. Do not put anything in the patient's mouth. Remove anything that can impede breathing or break. It can be eyeglasses, clothing, etc. During the seizure, what we have to do? Know the time it started and time it stopped. It is very important because if it is greater than 5 minutes or another seizure happens, it can be status epilepticus and activate the emergency system response team immediately. Notify the MD of the seizure regardless because the seizure needs to be investigated and check if the patient's drug level for anti-seizure medications is too low. When the seizure started, what was the patient's behavior right before and during it? Did they cry out, become confused, report an aura, become unconscious, and the characteristics of the body movements presented at the beginning and throughout the seizure? If the patient is having a stiffening of the whole body or just the extremities and then jerking or just jerking, was it on just one side or both sides of the body? Be sure to be as detailed as possible. This helps the healthcare team determine what type of seizure this was and what treatment may be given to the patient. Did the patient become incontinent of urine or stool? We have to check for oxygen status, cyanosis present or not. Next is a role during the post-ictus stage, that means after the seizure. Know the time the seizure stopped and how the patient is behaving afterwards. Are they tired? If let them sleep and rest. Are they confused? Can't think or talk? Have a headache? Ask where it is located and pain rating. Has any injuries? Some patient may bite their tongue or cheek. Maintain airway, do the suction and administer oxygen. If a tonic-clonic seizure present, the patient will be very sleepy, won't remember what happened. Assess vital signs and neurostatus, pupils, reflexes. Is patient confused or oriented? Clean patient if incontinence was experienced. Document and report it to the physician. Is this the patient's first seizure? Are they on anything for seizures? Is drug level not therapeutic? May need to draw a drug level if ordered. EEG may be ordered to assess brain activity. Hold seizure medications or medications that are stimulants or depressants prior to EEG. These medications can prevent the proper assessment of abnormal brain waves associated with the seizure. No caffeine products or stimulant is given to the patient 8 hours before. Patient can eat before EEG. Make sure patient's hair is clean to have good attachment to scalp. Different types of EEGs are taken. Some patients will need to experience sleep deprivation before the test by not sleeping the night before the test or only part of the night. Always ask about this.